This is the Common Health Podcast, a product of the CSIS Bipartisan Alliance for Global Health Security. We engage with diverse leaders on the question of how best to navigate this period of exceptional turmoil, reform, and uncertainty in U.S. leadership. We are aided throughout by our able producer, Marla Hiller. I'm delighted today to be joined by Stephanie Psaki. Welcome, Stephanie. Thank you so much for being with us.
Thanks, Steve. Thanks for having me.
Stephanie is a public health leader with expertise at the intersection national security, global health, equity. She just recently agreed to become a senior advisor to CSIS, to our Bipartisan Alliance for Global Health Security. I'm thrilled that you're willing to do that, Stephanie, and look forward to working closely with you. She served in the Biden administration as special assistant to the president and the inaugural U.S. coordinator for global health security at the White House, a role that included overseeing the federal government's response to several emerging threats. Mpox, Ebola, Marburg. We'll speak to some of that here today. She also got engaged in a whole range of other issues, including ending HIV/AIDS as a public health threat, investing in the health workforce, and expanding access to sexual reproductive health services and protecting human rights. She came into those positions with 20 years at NGOs and research institutions, including Partners in Health, FY360 Population Council. She holds a PhD from Johns Hopkins Bloomberg School of Public Health and a master's from the Harvard Chan School of Public Health, and has recently joined Brown University School of Public Health as a distinguished senior fellow. So I want to start, Stephanie, with a little bit more about your personal story. And what I mean by that is you started in one domain that didn't foretell that you'd show up in this other domain. So how did that circuitous route unfold? And say a bit more about, what got you first into the doctoral work and the postdoctoral work, and then how you found yourself coming over to the Biden administration.
Sure. Yeah, I think I've had a few of those pivots throughout my career. And, when I talk to young people now who are understandably feeling very uncertain about the future in this field, I think people want to have their full path figured out ahead of time and know exactly what their purpose is for the rest of their life. I still don't know what my purpose is fully in this world. And a lot of the opportunities that I've had and areas where I've contributed were not what I expected and kind of appeared for various reasons. So something I've been thinking about lately is that I went to Georgetown undergrad. And when I was a senior at Georgetown, I went actually thinking about being pre-med. And then I realized that I was more interested in public health, although I didn't know what public health was. And I don't think we even called it public health back then. And I wrote my senior thesis at Georgetown on kind of making the case that the United States government should play a more active role in combating the AIDS pandemic in Africa. And this was 2001. So I was a senior the year of 9/11. There was a lot of, rethinking and discussion happening in the United States about what the role is in the world for the US, and, a lot of fear and protectionism. And so I made a case that both from a human rights perspective and from just a self-interest perspective, the US government should be taking a more active role in addressing the AIDS pandemic. A lot unfolded, but long story short, I almost did not pass with honors. They almost didn't approve my thesis because part of the response I got from faculty at the time was, this is not really a human rights issue. The U.S. government does not have a responsibility to do something about AIDS in Africa because we didn't cause the problem, and therefore it's not our responsibility. Right. And it was a eye-opening. Now, people who are international human rights lawyers could explain in detail, why they were making that argument. But it was an eye-opening experience for me because it was the first time that, someone really said to me, not everyone thinks that we should be doing something about this. There are other things we should be dealing with. And in a lot of ways, I feel like that's the conversation we're having right now as a country about, how we spend resources, what our responsibility is in the world. So a lot has happened since then. But when I left undergrad, I couldn't find a job. So I waitressed for 6 months full time to pay my bills while I looked for a job. And everything turned out okay. I got a job. But my first job was working on USAID funded programs. Mm-hmm. This was, 20 plus years ago. And I was in my early 20s and, traveling all around Africa, in particular, meeting with mothers, especially, and talking to them about opportunities for their children, both in education, but also health challenges. And I did that for a few years, and I felt like I am not equipped at all, nor should I be flying around and talking to African women about the choices they should make for their children. It's really, really important to make sure that we're making the right investments. And how do we know what the right investments are? So that got me into the research world. I got a master's degree, as you said, from Harvard and worked at NIH for a year and then got a PhD from Johns Hopkins. And what drove me was really figuring out what tools we have to understand how we should invest limited resources to improve people's lives, both in the United States and around the world. So that's kind of been the through line in a lot of my career. When I finished my PhD, I worked at the Population Council. I started out as a researcher, kind of, shut in an office, analyzing data, publishing papers, getting NIH funding. But by the time I left the Population Council, I was leading a research center that was really focused on translating evidence for policymakers. So how can we give policymakers the information they need to make the most informed investments for adolescents around the world? And then I wasn't really interested or planning to join the government at all. But when the COVID pandemic happened, I felt like if ever I'm going to work in public service, this is the time to give it a try. So I started by working at the Department of Health and Human Services for the first 18 months of the Biden-Harris administration. And then, as you mentioned,
you were a senior advisor on gender-related issues?
I was a senior advisor on, I think, gender equity and human rights was my title in the Office of Global Affairs, which is the office that manages the relationship with the World Health Organization and ministries of health around the world. And then I joined the National Security Council for what was supposed to be a 90-day detail and turned into almost 900 days, where I worked on a range of issues really across the spectrum of global health. So as you said, kind of the bread and butter issues in the areas where the U.S. government has made the biggest investments historically, like HIV/AIDS, TB, malaria. But then in the last year that I was there, I was the U.S. coordinator for global health security, which was building pandemic preparedness, trying to prevent outbreaks, but also responding to outbreaks.
And that was a new position that Jerry Connolly and others in Congress had created, that you then became the inaugural lead.
Exactly. So it was created by Congress in 2022 as a reaction to the COVID pandemic and this feeling that we really need somebody at the White House that is tracking the biological threats from all sources around the world and making sure we're prepared for those threats, ideally minimizing those threats to the United States, but when they occur, making sure that there's a coordinated effort across the U.S. government to respond to those threats.
So that's an extraordinary trajectory. And you seem to have handled it while continuing to smile and be happy and be very productive. When you look back, and I realize this is all still very fresh, what did you think was your single biggest achievement? What's the thing you're going to be telling your grandkids about? Maybe it's not a single thing. And related to that is, what equipped you to do your job? Was it the field research? Was it the rigor that you acquired in graduate work? An ability to move fast and think analytically? What was it that equipped you to be successful once you got there?
Well, I will say on continuing to smile, there certainly have been many days in the last few months where I have not been smiling, but genuinely, it was such an incredible honor to be working in the government. I mean, of course, for President Biden, but to be working in the government and on behalf of the American people. It is not an honor that I realized I would feel until I was there. And then to have a series of opportunities and more responsibility, you feel the weight of the responsibility when you're there. So I feel very lucky to have had those opportunities. So in terms of biggest achievement, I think I would probably have given a different answer a few months ago than I would give now. But, a lot of the, I think, really important work that we did has been undermined or destroyed very quickly. So that's disappointing, but it also, I think, says something about the sustainability of changes that is an important area for reflection. I think, the most important responsibility when you work for the U.S. government, but certainly at the National Security Council, is to protect the American people. So I would say the part that I feel proudest of is that we faced many, many biological threats, some that people know about, some that they don't know about, and we kept the American people safe for 4 years. And that's the baseline that we have to work off of. In terms of what equipped me to do my job, I think that there is a lot of benefit to having a combination of people in any institution, but in the US government, who have spent a lot of time in the government and who have spent time outside of the government, because you have this cross-pollination of ideas. But I came in, surprised by the opportunity to work in government, excited to work in government, but fundamentally just committed to the mission of what I was assigned to do by the president, and not worrying about, teeing up my next opportunity. I was a political appointee. I knew that I would be out of the government, when President Biden was no longer in office. And that frees you up to really push very hard, I think, for the changes that you feel need to happen. Sometimes people are unhappy about it. Sometimes people are happy about it, both inside and outside of government. So I do think, even reflecting, and I'm sure we'll talk more about this, reflecting on some of the changes that are happening right now, there is value to having new ideas, new voices, new perspectives come into government. There's also incredible value to having people there who have been there for a long time, know how the government works, know what the risks are of changing things up. So for me, I think coming in from the outside was valuable because I came from a research world that was very focused on outcomes, what are the right investments to achieve the outcomes we need, and much less invested in the way things have been done in the past or the way we need to do things. I think that's valuable. I think having a grounding in science and evidence and training in these public health areas was very helpful. And you also realize how much the people who are chosen to be in these positions, especially the political leadership positions, really determines the direction of the policy and the extent to which the policy reflects the current science and the current evidence. If you have people in the positions who understand the science and the evidence, but more importantly, value science and evidence, then you are going to have more effective policies that are more likely to achieve their outcomes. If you have people who don't value science and evidence, who are coming in from a purely ideological perspective, you're going to have less effective policies. So I think that made me more effective in my roles and allowed me to pivot between different issues because I was less attached to the specific way of doing things and more attached to our job is to protect Americans. Our job is to achieve the outcomes with taxpayer money.
Thank you. Well, let's skip ahead now and talk about some of the recent developments where you have quite a bit of knowledge from your period in service to the government, but also just in watching what's unfolded in the first 100 days of the second Trump term. So we recently had what's called the pass back. You can explain what that is, but that gave us some fairly clear indicators of what kind of world we're going to be living in when we're talking about global health. We're talking about global health security. We've also had various leaked information around how the State Department and AID, which is ceasing to exist, how our instruments of government, our major structures are going to be redrafted, restructured in this next period. This is all in flux, we understand, but tell us what these tell us. Tell us what these suggest we're heading into in terms of the new realities.
Sure. So in terms of the process, in normal times, the president releases what we would call the president's budget on the inside, what the outside often calls the president's budget request, because it's a request to Congress and Congress ultimately decides on the budget. But there's a process within the executive office of the president that includes OMB to come up with the president's budget request. And once there is kind of a rough idea of what the president's budget request will look like, passback is sent to the departments and agencies so they can get a preview of what it's going to look like and get a sense of, what cuts are to come. And it's an opportunity for them to push back or push really hard for things that they think need to be preserved or moved around. And ideally, that input goes into the final budget that is released as the president's budget request. It's released publicly and also sent to Congress. And, depending on the composition of Congress, is used as the foundation for the budget that they come up with. So I think across the board, the president's budget request, wherever it lands, and this is probably a preview of where it's going to land, tells us what the priorities are and specifically how the president plans to align the budget with implementing his or her policy priorities. So some of this, I think in terms of what President Trump's priorities are, we've already seen unfolding. It's not particularly surprising, but I think some of it has raised a lot of questions about how it will be reflected in a budget. So it's useful in that sense. there's a lot of speculation. Obviously, Republicans control both the House and the Senate right now. So there's less kind of room for negotiation in terms of pushing back on the president's budget request on partisan lines. But I think that there are a lot of cuts that are laid out in these memos and in the priorities that have been shared by the White House that are likely in normal times to get pushback even from Republicans in the House and Senate. So remains to be seen how that will unfold. I am, taking a step back from both the HHS documents flying around, the state documents flying around, USAID, reorganization. Right. There's a lot of different memos, which I think probably did exist in some form inside the government, all of them. But I'm trying to take a step back and think a little bit about how we break down different types of actions that a president and an executive branch might take to enact their priorities. So I think one, and the one that certainly Secretary Kennedy has spoken most about in terms of the HHS reorganization, but I think is, ostensibly the goal of DOGE, is around reorganization and consolidation. And, if you watch the video that Secretary Kennedy posted before the HHS cuts were announced, it sounds pretty reasonable when you hear him describe it. He's saying there's duplicative systems, there's all these HR offices. We want to make sure that we are spending taxpayer money to improve life expectancy for Americans, improve health, not on duplicative functions. So we're going to undertake a series of reforms to achieve those goals. I think when I hear that, I largely, agree, not necessarily about how he would characterize the duplication, but we should eliminate duplication. We should use resources well. And we are not doing a great job in terms of using our resources well as a country that we invest in the health system to achieve good health outcomes, especially if we compare ourselves to other countries. So I agree with that in principle. And I think many people would agree with that. The challenge is, in practice, what has actually happened in terms of the cuts is that many of the top scientists and people with, decades of expertise and understanding and experience in terms of protecting Americans and improving health have been fired. And that is not what was described or previewed. What was described was duplicating, getting rid of duplicative functions, not getting rid of top scientists. I think pretty explicitly, Secretary Kennedy said they would not do that. So I think we need to compare what is being described as the goal to what is actually happening. And so when we look at what is actually happening, it seems very clear that there is at least some amount of essential work that is being cut. So there's huge cuts in the pass back to the NIH budget. Undoubtedly, yes, can you combine offices and centers? Can you find areas where you avoid duplication? Yes. But this level of cut to the NIH budget is absolutely going to have negative effects on the medicines and the interventions and the safety and well-being of Americans for a generation if this actually goes through.
So NIH is, in the current fiscal year, is about $48 billion a year, right?
Yeah. And I think it's like a 40% cut.
40% cut proposed.
Yeah. So that, in many ways, I think it's not something that Americans will feel in the short term. There might be examples here and there, but for the most part, it's longer term, which politically, there's an advantage to making devastating cuts that won't play out for a while, because then you aren't blamed for them. But I think that is essential work. There's also other areas where there are immediate impacts. Some of the cuts to rural health programs, cuts to, teen pregnancy prevention programs. There's just a whole range. The rescissions, the public health systems at the state level that are already having impacts on, the ability to respond to the measles outbreak, for example. So I think certainly what is happening is that there are cuts to essential work, although it's not completely clear yet what work is being kind of repackaged and put in different areas of HHS. And same thing, what work that USAID was doing is going to be in parts of state, et cetera. So I think to some extent, we still have to see how it's going to play out, and Congress has a big role to play. I think another piece that is clearly in the HHS pass back, but also we're seeing in other places, is this idea of cutting money from all sorts of places in the department and then putting them into what seems a bit like a slush fund for political leadership to spend on their priorities without clear outcomes in mind or clear guidance or oversight from Congress. So the idea is to cut the HHS budget from about $120 billion annually to $80 billion, and then to take a quarter of the remaining budget, so $20 billion, for this new administration for a healthy America that Secretary Kennedy would be, largely overseeing. Now, there's one scenario where that new administration is just combining different offices into one umbrella, making things more efficient. And, that scenario, while still very disruptive, I think would be okay in many ways. There's another scenario where it's not very clear what the goals or outcomes are. There's not a clear way to track success. And most of what they're focusing on are things like, announcing that by September we'll know what the cause of autism is, which clearly does not provide time to do any real science or research, but does provide time for advancing a political agenda. So I think as soon as you break down the structure and then create an undefined structure, it makes it harder for Congress and it makes it harder for Americans to see whether the taxpayer money is being spent on things that will actually improve health. And then the last piece, when I think about what to worry about and what to watch for, is just politicizing science. And I think we're seeing that, in terms of decisions about vaccines and decisions about where we invest in research. And that is, setting aside cuts to the budget, setting aside reorganization. If you have the political appointees intervening in decisions about science and decisions about which medicines are safe or not safe for Americans, that has immediate and pretty broad ramifications, regardless of everything else that's happening. So that's kind of what I'm watching out for.
And an overlay of this, it seems to me, is the whole concern around what happens on vaccines as a mega issue, right? Because you have the secretary coming in and announcing that this administration for Healthy America, AHA, is to be where the MAHA agenda is to be moved forward, right? Where the concern with chronic disease and all of these other populist notions that have been introduced in is to move that forward. And there's the concern that not only is there a downplaying of infectious diseases, but that the value and the approaches on vaccines are going to be changed in this period. Say a bit about that.
Yeah, I think that's part of what concerns me the most. And we're starting to see the contours of this not just being a Secretary Kennedy agenda, but potentially something that is woven in across departments and agencies. I mean, defunding Gavi, which has been doing life-saving work around the world for decades, saving millions of children.
That's the Vaccine Alliance.
The Vaccine Alliance. It's hard to understand what the reason would be. There's not an efficiency argument for that. There's not a public health argument for that. It actually puts Americans at risk to do that. So it's hard to see what the justification would be for defunding our vaccination work abroad, other than we're just undermining vaccination at this point, and that's the policy of the administration. So I think it's very concerning. And, to come back to the role of science and the independence of science, the challenge is if you get rid of that, you get rid of rigorous science, you get rid of independence of science. What criteria is the government using to decide what medicines and what vaccines should be available to Americans and not available to Americans? What if the criteria that start being used are that the companies that pay the most money in political donations are the ones that get their medicines approved? We don't know if they're safe. We're giving them to our children. It's not just the medicines that we're taking ourselves. So I think there are a lot of very scary ways that this can play out. It's not just about getting more information. We, of course, should have full, complete, transparent information about the safety of medicines and the safety of vaccines. But once you start to withdraw that process that we've had in place for a long time of making evidence-informed, science-informed decisions, it puts a lot of people at risk. And I think it puts the health of Americans at risk.
On the key foreign aid programs, just to encapsulate before we move on to some other matters, what's proposed is essentially a 50% cut in foreign aid. HIV is going to be kept at 2.5, 2.6 billion, 2.9 billion. The core treatment and prevention with pregnant women preserved, everything else gone. Global fund at a fairly healthy level. I mean, a cut, but still at $800 million a year. Global health security drawn down from $700 million a year to $200 million a year. Nothing on polio. Gavi's a blank space at the moment. Malaria, maternal and child health. This is giving us a bit of a preview of what is going to survive in what form. In other words, the revolution that started has wiped out AID. It's set back, made all of these enormous cuts at CDC and NIH. OGA is an office where you were at one point. Itself is in question. But we're getting an idea of where things may land in terms of the survivability of certain things. And it's not pretty.
Yeah, I think some of the cuts are not surprising. I am not surprised that family planning and reproductive health has been cut, although that is also going to have devastating long-term effects on the lives and health of people around the world. But others, polio, again, Gavi, the childhood immunization, others are very surprising and are not consistent with what the positions and policies have been of the Republican Party historically. We expect a certain amount of shifting in some of these areas, but in most of these areas of global health, the U.S. government's contributions has been fairly stable with some fluctuations up and down over time. So I think it's important to say that this is a huge departure from the role that the U.S. government has played globally for decades. And even at the levels that are for something like PEPFAR, $2.9 billion, it's far and away more than any other health issue in the budget. So in that sense, it's positive. But usually PEPFAR has an annual budget of about $4.5 billion. So it's going to require huge cuts. And as you said, it seems like the focus is on sustaining treatment, which is great and essential. And if we don't sustain treatment, especially without some kind of clear transition plan to countries taking it on, we will see a resurgence of HIV levels very quickly. So I think that's a smart choice. But to sustain treatment without widespread prevention is a very strange approach from a public health perspective to any health issue. So you are just going to continue to see climbing numbers of cases, more and more people who need to be on treatment, including, avoiding and eliminating interventions that are highly, highly effective at prevention. So I think there are some of what's behind this is a concern with interventions that focus on reaching key populations. So men who have sex with men, sex workers, injecting drug users, and wanting to kind of eliminate those programs. There are also, however, interventions like male circumcision that are some of the most impressive and cost-effective and impactful public health interventions in a generation. So it doesn't make a lot of sense. And it does feel a bit like there are people who know very little about public health or these health issues and just are looking at numbers and a budget and cutting it off without thinking through what the long-term impacts are going to be.
Yeah. Let's talk for a few minutes about a couple of other recent developments. On Mpox, you worked a lot on Mpox, on the global response. We had in 2022 and 23 an outbreak that emanated from West Africa, which moved into Europe and the United States, mostly among men having sex with men. That created an emergency. It created a declaration of a global emergency, a FIKE. The response there, the mobilization, was fairly effective, it seemed to me, in bringing case counts down, reaching the populations, not entirely successfully, but getting those testing, vaccines, antivirals, communications engagement, bringing those numbers way down. And then in the meantime, we had Clade 1A, a new clade, very dangerous, emanating out of the epicenter being in eastern Congo in the Kivus. That then arrives and poses all sorts of challenges. Tell us a little bit about where that stands right now. We've got a major war that's broken out. We've had the withdrawal of U.S. leadership. We've had contestation between WHO and Africa CDC. We've had financing and coordination problems. There's been some progress along the way, but it remains highly problematic.
Yeah.
I know you've invested lots and lots of hours into this.
Yeah. So let me start with the United States because, again, the core priority and responsibility when we were at the White House was thinking about protecting Americans. So first of all, there were a lot of lessons learned from the 2022 epidemic of Mpox, including that many people outside of the Africa region, including in the United States, thought this is never really going to be a problem that we have to grapple with because Mpox had been circulating in Africa for a long time. So there was a hubris to that, even while we were experiencing the COVID pandemic, that we didn't really, collectively, globally think it was going to be a problem. We were wrong, learned some lessons from that. And I think some of the lessons were to keep a system in place to prepare for Mpox in the United States so that we were ready for whatever came. We were watching closely, really, CDC was watching closely what was happening with Clade 1 Mpox for a long time in DRC, including, from the beginning of 2023, they were seeing trends where there were many more cases than were expected. In the end of 2023, CDC came to the White House and said, we're really worried about what's happening with Clade 1 Mpox. Something is changing. We don't know what's happening, but we need to start thinking about how to prepare in the United States for potential cases of Clade 1, which is different from Clade 2 in a lot of ways. And at least at that point, we were worried it would be both more severe, especially for children, and also more transmissible. It's turned out to be not very different. But we started planning then, a year before anyone was really talking about what was happening. We set up a response structure within the US government in early 2024. We had a plan to make sure that if any cases were imported into the United States, one, we would know that they were imported, Clade 1, not just Clade 2. We would be prepared with treatments and with vaccines, and we would have a way to quickly contain any outbreaks before they spread further. Long story short there, as there have been 4 cases of Clade 1 Mpox in the United States, 2 in the Biden administration, 2 in the Trump administration, all were quickly contained and identified, and there was not further spread. So in terms of domestic preparedness, that is a success story. And that is because we had the systems in place to prepare for over a year in a way that was under the radar, indiscernible to Americans, but also means it's not something that Americans are worrying about right now. The rest of the world is a different challenge. Yeah. And as you said, this outbreak continues to accelerate. Actually, it's getting worse in 2025 than it was in 2024. And 2024 was worse than 2023. Even though when the FIIC was declared almost, we're 9 months, we're approaching a year since the FIIC was declared, we were ready. And there were pretty quick announcements from a lot of high-income countries that they were going to support the response. So I think it showed a lot of progress since the COVID pandemic in terms of the willingness and preparedness of high-income countries to pledge vaccines to the response, to pledge resources. President Biden pledged $500 million from the U.S. government.
This was at the UN General Assembly
At the UN General Assembly, exactly. And up to 1 million vaccine doses. Yes. And many other countries, because these vaccines were stockpiled for national security reasons, many other countries stepped up quickly. So there were positives there. However, there were a lot of negatives and challenges in this response. So there was a long delay in getting regulatory approval for Jynneos, which is the vaccine that is produced by Bavarian Nordic and used most widely in the United States and in the Africa region. Even though we saw this coming for a long time, Bavarian Nordic had been in discussion with WHO for a long time.
Sharing its data since 23.
Exactly. They had not gotten regulatory approval, which meant that as things began to shift, even before the FIIC, we could not get vaccine donations into DRC for a long time, and there were a lot of delays as a result in countries preparing to vaccinate. So that is something that countries are still getting up to speed on, because once you have regulatory approval, there are many, many other steps that are, topic for a different podcast of getting those vaccines into countries. So I think that was a delay, and there's just a broader problem in the regulatory system strengthening, in liability and indemnification issues, in the cost of the vaccine and access to the vaccine that we still need to grapple with, because this has really pointed out those remaining issues. One of the things that we also, from the Biden administration were focused on is getting clarity on this question of, is there enough financing in the system to respond to a crisis? So it was also a lesson learned from COVID. And in Mpox, we worked through the G20 actually to do a rack and stack pretty quickly of how much money was in the system to meet the needs, to get a clearer picture of where the gaps were, and also to make sure that countries who needed resources knew where they could go to get additional resources. So we worked on that through the G20. Most of that, unfortunately, was never shared publicly, but the bottom line is what the G20 Joint Finance Health Task Force found was that about 90% of the resources that were needed for the Mpox response were available or pledged from high-income countries or other donors pretty early on in the response. So there are other challenges with getting those resources to the field, making sure that they're matched to what the needs are. But in a lot of ways, this is successful in terms of vaccines and money being available. So why are we still where we are right now? And I think that, unfortunately, I don't have an easy answer to that question, but I think it is a question we really need to be grappling with in the global health space, because the solutions that we are trying to build to prepare ourselves for the next pandemic, including what's in the pandemic treaty text that was agreed on last week, a lot of those solutions are kind of mirroring what we just did for Mpox, and it's not working to contain it, or it's not working fast enough, or it's not enough. So I think we need to ask ourselves some really tough questions about what are the barriers that remain right now with a pretty slow-moving outbreak relative to something like COVID or a respiratory pandemic, where we're going to need to act much more quickly to get it under control.
Thank you. You mentioned the pandemic treaty. Say a bit about what has just happened. They've just announced some resolution of a sort.
So last week, it's very strange to not have been at the center of this, because another area that I spent a lot of my time on in the last few years in government was working on the U.S. government's negotiations, part of the negotiations for the pandemic treaty. And last week in Geneva, 194 WHO member states, with the exception of the United States, agreed on a text for the pandemic treaty that presumably they will adopt at the World Health Assembly next month in Geneva. So I am very pleasantly surprised that there is agreement. I think it's a huge win for multilateralism. It's really great to see that on such complex, difficult issues, especially in a very complex, difficult time, WHO member states can come to agreement on the framework for what we should do to prevent and respond to the next pandemic. I think we really need to pause at that win, because there were many moments in the last 3 years where it seemed like even coming out of a pandemic of a century, we're not going to get there. So I'm very heartened to see that they've reached this agreement. I wish the United States was at the table for it, but I know that the work that we did fed into the text they landed on. That said, some of the most difficult questions are still unresolved and need to be resolved in the next year or so.
And we'll see more discussion on those. But, when things failed to reach resolution last year, there was a sense that the divisions that were born out of COVID between the global south and global north, between the low-income countries that were most severely disadvantaged and the corporate sector, that these animosities, these confrontations, these residual problems that were highlighted during COVID were just too big to get overcome.
Yeah.
And that this process of over 2 years of negotiations had failed.
Yeah.
And then suddenly we have this thing happen. Okay, they took some of the more difficult things and parked them and said, we'll come back to those later. But my sense is that Trump's arrival stirred people into action.
Yeah.
You agree?
I think that's right. And again, I also really do think that we were engaging in good faith and made a lot of progress. The truth is that the final text is not that different from where we were a year ago. So I wish we had agreed on it a year ago, but I think there was a lot of work that went into getting us here. What concerns me, though, so yes, I think that President Trump's arrival and the shifting role of the U.S. government in the global space spurred action, and also maybe was a bit of a reality check in terms of how likely it is that things are going to get much better than the deal that's been on the table for a while. But what concerns me is that it does still seem like the structure that this is based on a world that no longer exists as of the last few months. It still is very dependent on, set-asides from manufacturers and low-cost donations from manufacturers, but those don't happen unless high-income countries or, middle-income countries are procuring large amounts of countermeasures and are willing to pay a higher price for those countermeasures so that some will be made available to low-income countries. Manufacturers are not going to absorb the extra cost. The cost is going to be passed on to high-income countries. And the structure is still dependent on there being an agreement that, rather than hoarding vaccines, countries are going to be willing to share them early on. I feel like we are less in that world now than we were 4 or 5 years ago. So I also think in the next year, and as we reflect on where the text is currently, we still need to have, again, some very difficult conversations about whether this system, even if we set it up, even if manufacturers opt in to the legally binding contract that would force them to set aside some of their production, will that mean that we have vaccine equity in a pandemic? And I have real concerns that it won't, because there are a lot of issues we still have not resolved, including just, diversifying manufacturing capacity beyond the capacity that's centralized in high-income countries. What does it look like to get manufacturing that's happening in the Africa region? You also need a functioning regulatory system. You need staffing. You need investments in facilities and sustained investments in those facilities. You need a demand and a market for those products. We haven't really grappled with a lot of those issues at a large scale. And until we do, I don't think we are fundamentally going to change the calculation in the next pandemic.
Thank you. Let's close by talking about where do we go next here in the United States in thinking about future of U.S. approaches and leadership in global health security. As we've talked about, massive setbacks that were unthinkable a short time ago. Survival on a much smaller scale of some priorities, continued high uncertainty. I think it's understandable that as these changes were unfolding with a ferocity and a speed that none of us had expected, that the first reaction was shock, trauma. Oh my gosh, how could this be possible? A lot of folks mourning the loss of those programs, of those staff, of that expertise, of the benefits of what was created to the populations that were being served, that were very deserving and vulnerable populations. So all of that registered. But at the same time, we need to be thinking ahead. We need to be thinking about what will a new consensus look like that can draw support across political lines. We have to first ascertain what survives, but we have to begin to a process of discussion that is both self-critical of some of the failed reforms that never happened in the earlier period, and also this sort of where are the central values going to be? How are we going to get people refocused normatively and strategically on what we have lost and given up that needs to be reconstituted in some form? And it's not going to look at all like what it was before. The models for delivery, the big programs are not going to be restored to status quo ante. So we need some kind of forward vision. I know you and some colleagues have been giving this a lot of thought. It's something the Alliance needs to turn its attention to intensively in this next period, because I think we're entering that moment where this is really becoming an important imperative. And say a bit about this. You've already put your mind to this in a significant way.
Yeah. So I think that you described very accurately what the kind of, stages of grief have been in much of the global health field over the last few months. And I think that the emergency response work to what's happening and, sustaining some core capacities and making the case about the dangers that these changes present is important. And that is essential and needs to continue. But as you say, I think we need to be thinking about what our vision is and building the vision that is a better vision of what was there before. And some of that is, discussion and agreement that there was before, and maybe we didn't move on it as quickly or as effectively as we should have. I think there's reflection needed there, including things like, the sustainability of investments and when national governments are taking over the costs of things like ARVs in the PEPFAR program. But some of it is also really forcing ourselves to think differently. We are in a fundamentally different world from the one that we were in when these structures and systems were created decades ago. We are also in a fundamentally different world from the one that we were in a few months ago. And trying to think about a, USAID light or a, slightly adjusted system that looks very similar but smaller to the system we had before, I think is the wrong way to go about it. So for us, we are wandering in the desert, and now is the time to have conversations among ourselves, but also with people from outside of this space who think differently and see the world differently about what we could do differently. So, one issue that I think many people would agree with in the global health field is that these siloed disease-specific programs are an inefficient and, ineffective in some ways way to advance health more broadly. That doesn't mean there's no place for disease-specific focus or outcomes or indicators, but shifting from those silos, which were largely imposed by Congress in terms of the structure of the funding, to something that is more integrated would be a more effective and efficient system. So I think that's one area where we should be able to do some thinking and make some progress. As I mentioned, I think serious conversations about the sustainability of investments that are not just, some agreement that in the next few decades countries will take on costs, but more concretely linked to the funding, more concretely linked to policy changes and to investments. I would love to see a commitment. All of this needs to be coming from the countries themselves, but I would love to see a commitment to paying health workers, to that being part of national budgets across the board, and that no longer being something that donors are covering, which also gives countries a lot more autonomy and control over the services that are provided in their communities based on what the needs are. So I think that needs to be a dialogue with countries in terms of what's going to be covered in budgets, but it would be helpful to learn more. I think we need to do some real re-envisioning about the financing space. And this was work that we started in the last administration. But I think coming out of the COVID pandemic, there was some progress, but it was kind of ad hoc and, small scale and not large scale enough for the size of the challenge. And it was largely focused on the pandemic preparedness and kind of surge financing in a pandemic space. There now is a broader financing conversation that needs to happen about health issues across the board, but also development across the board. What is the role of international financial institutions? What is the role of DFIs? DFC has been a leader in some of these conversations with the rest
Development
of the
Finance Corporation.
Development Finance Corporation, which was created by the first Trump administration and seems to be, surviving through some of these changes. What is the role of the private sector? I think there's been a lot of discussion of the private sector taking a more central role and a more proactive role, but we haven't really seen it happen in any large way. So is there a version of that is workable, or is it just not likely to, be the savior that we're waiting for? So I think we need to have these financing conversations. And then last, and, as you said, global health security seems to be surviving, at least initially, with a much, much smaller budget. But the preparedness for biological threats within the United States, preparedness and prevention around the world, and response around the world, this is not charity. This is not development investments. This is fundamental to our national security. And so those, $200 million a year is not sufficient to actually prevent threats from emerging and coming to the United States. And so I think even now in this moment, envisioning a different reality where that for every administration with continued bipartisan support is integrated into national security, into defense, and into homeland security, I think is essential. So these are just some ideas, but
But those themes together form a corpus. What you've just walked us through are the core themes for rethinking.
Yeah.
Where we go here, and it needs to be put into a language that is intelligible across political lines.
Yeah.
And some of this is possible, I think.
I think so too. And hearing across political lines what the reactions are, having a real dialogue, within the global health space, but also really hearing from creative people and thinkers and areas outside of the global health space about how to do things differently. What is the role of AI? We hear so much about the promise and possibility. How can that help in this moment? I think in a lot of the conversations we've been having in the last few months, there's a tendency to overcorrect sometimes and say, well, the only reason we are, making these development investments is because it helps our national security or it's self-interested. And there is, a fundamental motivation, I think, for many people who work in this field, but also for Americans, that is
ethical and
compassionate. For whomsoever much is given, much also shall be required. Like that is what has guided, I think, a lot of the creation of PEPFAR, but a lot of the work that the U.S. government has done around the world. And just saying, I think it's okay for us to say, part of the reason that this work is essential and important is because there are children who are going to die around the world without some of these services, without food when they are malnourished, without routine childhood immunization, without safety. That is reason enough to continue doing this work. And let's have that debate. Maybe we'll lose that debate, but I think that is part of the motivation, and that's part of the justification we should be giving even as we evolve this to the next stage.
Thank you. Let's close, as we do always, asking our guest to quickly tell us what gives you the greatest hope and optimism in this moment that we've all admitted is a pretty dark and uncertain moment, but one that we have to deal with. So where's your optimism and your hope?
So, I mean, this is a very Joe Biden response, but what can I say? I worked for him for 4 years. I believe in the American people. I really do. And I think the people in Washington are, we're all a little crazy and don't really represent, on both extremes. We don't really represent where most Americans are. Most Americans, I think, have good hearts, want to do good things in their community and in the world and for each other, want to support one another. They don't want to pursue hatred. They want to pursue stability and taking care of their families. I think that the work that we've been doing around the world is something that connects with a lot of Americans on a very fundamental level. And if you look at the polling data, you can see that most Americans continue to support it. But I also think that Americans want to keep their families safe and keep their communities safe. And fundamentally, if there are cuts or changes happening that make that harder, I think they're going to push back and disagree with it. So we have to sometimes take some deep breaths and watch it play out and just make clear-eyed cases and then allow Americans to respond.
Thank you. And thank you for all of your service to our country, Stephanie. Thank you for that. Thank you for being part of CSIS now.
Thank you for having me.
And it's great to have you with us and for taking the time today. This has been a wonderful conversation.
Thanks, Steve.
Thank you for listening to The Common Health. If you enjoyed this podcast, please give us a follow and leave a review. To learn more about the CSIS Bipartisan Alliance for Global Health Security or listen to other CSIS podcasts, please visit csis.org.